Hello, and welcome to the Encephalitis Podcast. My name is Prav, and I'm from Encephalitis International. Today, we'll be talking about the experiences and challenges of being a parent who is living with the effects of encephalitis and brain injury. One of the terms we'll be using today is ABI, which stands for acquired brain injury, which is an umbrella term that includes tumors, strokes, encephalitis, amongst other conditions. So to learn more, I'm grateful to be joined by Dr. Freddie Byrne. Dr. Freddie Byrne is a clinical psychologist and clinical director of Living with ABI Limited, an organization dedicated to improving the lives of acquired brain injury survivors and their families. Dr. Byrne has a special interest in family well-being and relationships following a brain injury, with over 10 years experience in this field. Dr. Byrne has completed further training in family therapy and is passionate about applying this knowledge to supporting families living with acquired brain injury. In 2019, he traveled to Melbourne to work with the internationally recognized Bovary Center to train in their single-session model of narrative therapy for families living with ABI. Dr. Byrne is also a guest lecturer at the University of Surrey and volunteers with Headway UK as a support group facilitator. Thank you so much for joining us, Dr. Byrne. Welcome to the Encephalitis Podcast. How are you doing today?
Very well, thank you, Prav. It's great to be here.
Wonderful. So to start off, could you begin by telling us a bit about your background and experience working with families affected by brain injury?
Absolutely. So my journey started even before I qualified as a psychologist, volunteering with a rehab charity up in Birmingham. And that was the first time that I started to become exposed to acquired brain injury and meet with different survivors and see what rehabilitation can look like in the community. And then later on, once I'd qualified, I worked with the Queen Elizabeth Foundation in Banstead for a few years. And it was there that I completed my further training at the Tavistock in family therapy, because I was always really struck by how different everyone's journey through rehabilitation and after a brain injury looked. And it really seemed to me that one of the really key defining factors was the family that they had around them, how present people were, what kind of meaning people made of it, the family relationships and communication that was there. That really seemed to be such a defining factor for what shaped people's rehabilitation journey, as well as actually just seeing the distress and hardship that was faced by the families themselves, and often the lack of support that's really available. And I was really fortunate to be able to complete the family therapy intermediate training whilst I was there and establish a family clinic and start to make space for inviting families into the psychological therapy sessions and assessment sessions to really bring in different stories, to hear things that we might not have heard otherwise about the survivor, about how they're doing their rehabilitation, and to work both to support the family members as well as to support the family members entering into their new caring roles.
Talking about the changes in roles and family dynamics a bit later on. But before we get into that, when we talk about parenting after brain injury, what kinds of situations or challenges are we really referring to?
Well, I think that when we're talking about acquired brain injury, such as those caused by encephalitis or other events or conditions, we're talking about a population of people that are really, really, well, in research, we use the term heterogeneous. So everyone's really, really different. And it's the same with families, isn't it? You know, we grow up and we kind of assume the family that we grew up in, that's what families look like, and that's how we do family. But actually, as we get older, as we go out into the world, particularly for those of us that have family therapy training, you see actually just how different families all are. How we make sense of the world in different ways, how we all have these kind of implicit rules and styles of communicating what's allowed and what's not allowed in families, issues of pride and shame. So families are incredibly diverse, and brain injury is incredibly diverse, depending on the areas of the brain that have been affected by the injury, the nature of the injury itself, the context of how it came about. So when we're talking and thinking about parenting and families with encephalitis or other forms of brain injury, it's a hugely diverse population of people, really. And I think that's something that's really important to hold in mind.
Absolutely. And when you're working with families, how do you balance parent recovery with the child's development and emotional bonding?
Well, I think that families and parents living with encephalitis and acquired brain injury are dealing with a really complex constellation of issues. So there's the episode, for instance, where the person has become unwell and whether they've acquired the encephalitis. And those episodes, which will include multiple contacts with hospitals and other services, they hold a lot of potential for traumatization, both for the survivor themselves, but also for the non-injured parent, assuming it's a two-parent family, and in particular the children as well. And a really high proportion of family members can often, what we find, meet the criteria for post-traumatic stress disorder. And even if they're not meeting that criteria, then they might be expressing and experiencing their distress in lots of other ways. So I think that that's one issue that's really important to think about. And I think it's important to think about, what was that journey through the person becoming unwell, the deterioration, the contact with services, and then their subsequent rehabilitation and recovery journey. And they're often what we might think of as like hot points along the way that are really important to be thinking about. So when the person was becoming unwell, who was around them? Were children in the house, for instance? We have to think about how children make sense of the world, and often they're thinking about things in relation to themselves. Inherently what we might call egocentric. They're thinking about themselves all the time. We all are, but children in particular, I would say. And so, there's lots of potential for like an inflated sense of responsibility when a parent becomes unwell, or thinking that something might be because of them, or that they could have acted, in some way along the way. Or it might just be actually that, when we think about trauma, we're thinking about someone living through something that's unspeakable. And actually, often it's something that either is completely at odds with what we might call as a psychologist, their schema. So this way that people have, and children and adults will have, of making sense of the world. So they're kind of thinking or cognitive structures that we look at the world through, because we're very good learners and children are learning all the time. So and we want to be cost effective in our interactions with the world, so to speak. So we're constantly developing stereotypes, ideas, or these schemas, these kind of mental frameworks for looking at the world. And if a parent suddenly becomes unwell, then that can be something there's no schema for it. So it's completely at odds with what was hopefully a sense of predictability and consistency in family life. And so then that can be something that's really, really difficult for the young person to process, and may also be very, very difficult for the survivor and other adults to process. So everyone's dealing with this in their own way, and therefore some support is often needed. Or because things like encephalitis or other brain injuries don't always come, there's no good time to acquire these types of injuries. And sometimes they may already be stresses, stressful family events, or other traumas going on in that young person's life. And therefore, that traumatic event is then encoded into a period of time that may have already been a very high stress time. And that can then leave the young person even more vulnerable to post-traumatic stress disorder. So I think that that's something that's really important to think about, that those, the potential for trauma along the way. And it can be when young people might be brought into the hospital. It can go often either two way, one of two ways. In the family might take responsibility to say, actually, this isn't appropriate for the child or young person to be exposed to this. And so then they might really try and protect that young person or child from what's happened. And sometimes that means actually that they're not informed and they don't know what's going on. And that can be distressing, because then there's no story to hang around what's happening. They know that something's not right and their parent may not be there, or they may be changed, but there's no story or explanation around that. Or the other end of the continuum, sometimes children are brought into hospitals and trauma centers are often really unsuitable environments for children and young people, because the staff, understandably, may be focusing on keeping people alive or supporting people with their recovery and their rehab. And so then children might get exposed to things, either seeing their parent looking very different, looking very unwell, or maybe in a confused or agitated state, or perhaps seeing other patients in that state, or worse, and that can hold a lot of potential for traumatization as well. So I think that's one aspect that's really important to think about. I think then other aspects are thinking about the change in family relationships that can occur. So what we know from research and what I see in my clinical experience is that brain injuries such as those caused by encephalitis or other causes, that can impact on the survivor's capacity for parenting. So it might be that the injured or surviving parent is showing behaviors that are confusing or distressing for the young people. It might be that they struggle with what I would think of as executive functioning, using the language of neuropsychology. So our executive functions are a high level thinking process. They're like the executive in charge of the company, or the pilot on the plane. So our ability to focus our attention and switch our attention between things, or multitask, our ability to think about the context we're in, our social environment, and to switch gear according to the different setting that we're in, our ability to plan and problem solve, and ultimately to have a sense of our preferred identity and our life goals, and to choose our behaviors to shape that. And for most of us who are parents, hopefully our key life goals really are to bring our children up in a way that is supportive of their potential and their well-being. And then that might become something that actually becomes quite difficult, because the decisions that are made here and now in the moment might be much more based on how that injured parent or survivor, how they're feeling, what's going on in their environment, things like pain or hunger or fatigue, and that capacity to hold in mind those really important parenting goals can actually, it can be really difficult for them to think about, actually, how do I shape my behavior in order to support my child's development. And so the child can experience that injured parent sometimes as changed. And that can be uniquely distressing, that sense of, because for children, their parents are their source of security and safety, aren't they? No matter what's going on in life, actually. What we know from attachment theory is that that's how young people go through the world, how they develop their sense of safety, their sense of identity, how they make sense of the world. It's through family relationships and relationships with our primary caregivers. And if children experience their parent as a different person or changed, then that can be uniquely distressing and potentially traumatizing for that young person. So there's the trauma, there's the young person dealing with changes in their relationship with the injured parent, but then we have to zoom out as well and think about what's going on in the wider family, because assuming, again, it's a two-parent family, then the non-injured parent or other guardians or supportive adults in the network, they will also be dealing with similar events in a different way. So this sense that their partner or that their loved one has very suddenly perhaps become unwell, and then there's a sense, and they've experienced this, and there can be traumas that go along the way with that, including the contact with healthcare services, like I spoke about earlier. But they might have a sense that their loved one is changed as well. So you had Dr. Giles Yates recently on the program, and he was talking about personality changes, wasn't he? And how often the first signs of what we call personality changes are coming from the reports of loved ones or caregivers. And so it can be that the encephalitis or brain injury survivor themselves, that their self-story doesn't include some of the content that's in the stories of the other family members about, what's happened. They might have what we call like narrative discontinuity. So they've lost a period of their memories where they may have been unconscious or in an induced coma, or in an early, very agitated state. But then also they might not have developed that same awareness of how they've changed as a result of the difficulties that other loved ones might have. And so that inherently creates this sense of disconnection and that exists in the space between people. And so, as well as the loved one supporting their injured family member, they're dealing potentially with this sense of trauma, or what we might call ambiguous loss. This sense that my loved one is changed in some way. They're still here, they're still physically present, but actually my sense is that they're not here anymore, or that sometimes they're here and sometimes they're not. And that's sometimes what we call ambiguous loss. And that's not necessarily seen and understood by wider society. And then that becomes what we call like disenfranchised grief. There are no rituals or ceremonies or funerals for a loved one who might be irrevocably changed as a result of encephalitis or a brain injury, in the same way that there is for someone that we've lost as a result of a bereavement. And so then that can be left unseen by wider society. And what that means is that then the other adults often have less practical and emotional resources to provide to that young person, that child, their children or young people in the family who are dealing with the issues that we've spoken about in terms of the changes in relationships with their injured caregiver. So the children can experience this kind of double loss in a way, the loss of that relationship as it was with their injured parent, but then also that their non-injured parent or other family members or caregivers might be so caught up in dealing with these issues and so overburdened with care responsibilities and needing to fight and advocate for services and care that actually they might have been away for 6 months in hospital, or they might just have nothing left in the tank at the end of the day. They might not be able to take the young person to school and pick them up and help them with their homework, or they might not have those emotional resources to show that love and containment to a distressed and traumatized young person. So that's another thing that can go on. And again, we can see similar things with siblings that can happen in the family if it was a young person that sustains the injury. Although today I think we're going to focus on where it's the parent. So there's the trauma, there's those relationship changes, and then there's also just those added caring responsibilities, or how they make sense of, a parent that might be behaving in ways that require a lot of care and support. They might be behaving in ways actually that are quite dangerous and risky. And so then there might be like an inverting of those parenting relationships where the young person feels that it's their job actually to keep their injured parent safe, particularly if maybe the non-injured parent is at work. And then that all happens in the context of wider social changes. So it might be that actually the family are suddenly facing financial hardship in a way that they either weren't before, or that's worse than they were before, because one or more parent may not be able to work anymore. There are additional caring responsibilities which can have financial implications, but also there's this peeling away of social support that we know can happen over time, where people can become more and more isolated and families can become more and more isolated. So it's that really challenging constellation of difficulties that families face. And coming back to your question, you said, how do you prioritize the needs of the injured parent alongside the needs of the child? And that's something that's really tricky to do. I think it's not a straightforward thing. And I think that we live in a very individualized society, and our health and social care services are typically very, very individualized. And whilst there is an exciting movement, and there has been for the last 20 years or so, towards professionals in healthcare and neurorehabilitation in particular, thinking about the wider family system and how we recognize the impact on children, young people, and the wider family through research and through service provision. On the whole, services are still very, very individually focused. And so I think that that's something that we do need to keep working on as professionals. But ultimately, I think that, the needs of the child needs to come first in any healthcare scenario, even when we're dealing with vulnerable adults. And that can be something that's can be challenging for families because they're dealing with an impossible scenario that no one can really imagine unless they lived through it. And there's always the opportunity for what I would call parallel processes in professional networks and family networks, where it might be that the needs of the child are getting lost and they're getting missed within the family, because there's such a need to process what's going on and to support the injured parent and family member. And the risk is that we have this, what I would call like a parallel process in professional networks, where children might get forgotten about and not thought about. And unfortunately, we're still in a situation in the UK where, if someone presents at hospital with encephalitis and goes on to sustain a brain injury as a result of that, there's no formal mechanism for actually recording they're a parent and there's a child in this family. Of course, it can happen, and children can be flagged up to social services, but there's no one mechanism that happens, across our healthcare systems for doing that. And that's something that's really tricky as well, because it's not then setting in motion a kind of a cascade of support and services that should be in place.
And how do family roles often shift after a parent experiences encephalitis or brain injury? I know this is something you've touched on, but just want to give you a chance to delve into this deeper.
Well, I think that they change in all kinds of ways, and all families are different. And so it may often depend on who is it that sustained the encephalitis, the brain injury, and what were the roles that they played beforehand. So I don't think that there's necessarily good research to suggest gender differences or difference between mums and dads. That there is some differences that are highlighted in the research where children might be more likely to be traumatized if it's their mother in certain ways, perhaps because they might be playing that primary caregiving role. But we're dealing with such a diverse population. Like I said, all families are different, and all brain injuries are different. So it really depends on what the family looked like beforehand. And whilst we're often dealing with imperfect research, with retrospective designs, where we're speaking with families where they've had a brain injury and looking back, or where there are small sample sizes, or they don't have a control group, like another group of families without a brain injury to compare. There are things that come up in the literature that suggest that there's this idea of family functioning. How is the family doing beforehand? How do they support one another to meet their developmental needs as a family? How do they listen to one another? How do they support each other emotionally, for example? And the suggestion is, particularly for milder brain injuries anyway, or mild to moderate brain injuries, that where the family is already struggling in their functioning, that can be a predictor that actually then, funnily enough, that they're more likely to struggle after a brain injury, such as one caused by encephalitis. And some research will even suggest that the family functioning is a greater predictor of different healthcare outcomes and different rehabilitation outcomes, or how each family member is doing down the line, than the severity or the nature of the injury itself. So it's something that's really, really important for us to understand more about. And so there's these changes in family functioning, which may be related to the pre-existing ways of functioning that the family had. And then there's this increasing of caring responsibilities that can take place, where a non-injured parent and an injured parent may have to step away from work to either step into that recipient of care role or provider of care role. I think that the same can happen with children and young people, where they may have to either step out of education, or may not have the same resources to devote to their education because they're having to step into these caregiving roles. But also there can be this sense of changed identity and loss, which I think is another aspect that comes with, like, there's the role change, but then there's also the identity change. how the family and individuals in the family see themselves and understand themselves. And there can be those biological causes, those personality changes that might come with encephalitis or another type of brain injury. But then there's the changes of needing to step away from work and not having that same sense of vocational identity and work relationships. And then, if we think about children and young people, depending on their developmental stage as well, they might get more of a sense of their identity from their social relationships or being in school, which can be something that can be protective if that's a consistent factor. But what can make that challenging is actually that there can often be a lack of understanding, amongst healthcare professionals, amongst young people's friends, amongst other family members. And so then there can be this kind of well-meaning effect where people might be saying things like, it might all be about the parent. How's the parent doing? Or they might be saying, aren't they doing well? It's something that people really consistently hear. Or, sometimes people, I'm sure well-meaning, will even kind of say, no, they're the same as they were, which may be coming from a reassuring place, but the effect of that can be that actually it's like that disenfranchised grief again, that then it's only what happens behind closed doors. It's only the children, the young people, the partners, the family members that see these subtle but really important changes. And so then there can be a sense of threats to identity in that respect, because people aren't really kind of understanding what you're going through as an individual and what you're going through as a family. So I think there could be both those role changes and those identity changes. And of course, human beings are really resilient, and it's a balance, isn't it? And it's important to understand the challenges and the hardships that families can face. And it's also, it's important to make space that for some people, there is also that sense of post-traumatic growth that can occur, those new connections that can be formed, particularly, you mentioned I volunteer with a group called Headway, which is one of the UK's largest charities for supporting survivors of acquired brain injury. And they run lots of wonderful services in different boroughs. So we run a support group, and that can be a space where people can create new connections, both between survivors or caregivers and family members as well. So I think that doesn't fit for everyone, because these are really challenging circumstances. So I think it's a really careful balance between, bearing witness to actually what has happened and having some sense of how things may have changed in really difficult ways, whilst also, holding and creating some space for the fact that there'll also be growth and resilience and a sense that, people have achieved things that they didn't have, they never knew they thought possible, because it may be that the person with the encephalitis and the brain injury, that the roles that they took up in the family, whether those are practical things like, washing the car and managing the finances, or whether they are more subtle things like providing that emotional support to one another or to the young people, that can a kind of vacuum can be created there. And then other family members may have to step into those roles and take those roles up. And then that obviously creates opportunities for growth and personal development, because people are developing resources and skills that they didn't have before.
Wonderful. Thank you, Dr. Byrne. How do you go about sharing the difficulties and challenges one parent has with the other parent who might not understand completely the impact?
Well, I think that this is something that I potentially approach in a slightly different way to other clinicians, because I work in neuropsychology, but I would think of myself as a systemic practitioner. So it comes out of systems therapy, and it's a particular branch of psychology and family therapy that's about how do we make sense of people within the systems that they're in, and that might be family systems or wider social political systems. So I give a lot of importance to working with family members as active partners in the process. And so I contract things slightly differently to I think many other clinicians might typically do. So usually, we have clinical confidentiality, for example, as part of services. So, someone has the right to that confidentiality within a healthcare setting and relationship. And that's something that's really, really important. And there's lots of professional guidance around that. And typically we might contract that if we're part of a large team, that we will share information as part of the team, as part of providing care. And what I would routinely do is actually, wherever, the majority of the time where it's appropriate, is to contract that in a way that includes the important family members within that system, particularly if there's a partner who's the primary carer in that situation for the injured parent. I would, or it may be a parent or another important adult in the system. And so what I would generally seek to do, and obviously I'd be wanting to seek informed consent and make sure that a person had capacity to make that decision, is to contract confidentiality in a way that allows information sharing with those other important adults, just in the same way that we would do with the caregivers team. And on the whole, I find that actually that's something that the survivors themselves are really grateful for and really open to, because family members are the most important people in their lives and the most consistent people in their lives. So that's something that I routinely seek to do, so that we're not in a space as clinicians that we're getting bound up in red tape around confidentiality and what we can and can't share. So we're in a position to actually share information that they really need to know as part of providing that care. Because whenever I meet someone as a clinical psychologist, I need to hold in mind every session could be my last. The person's coming to see me because hopefully they're benefiting from it and they vote with their feet. But that could be the last time I see them. And ultimately, their family are going to be the ones who are there at the end of the day. They're going to be the ones at the end of the phone. If things aren't going well, they're going to be the ones who are there on Christmas Day. So I think that's really important, to be able to routinely share that information and keep family members up to date. But it is complicated as well, because so I would contract confidentiality in that way. But I would also try and make space to meet with family members by themselves, because it might be that there are stories that they are important for them to share about their brain injured loved one that actually they're not able to share. They don't feel safe to share, or for whatever reason don't want to share in front of them, whether it's that they don't want to be disheartening or get in the way of their rehab, or whether there's a safeguarding issue or some domestic violence. So on one hand, I want to contract with that survivor. If appropriate, we can share information with family members. On the other hand, I also want to meet with family members and for them to feel confident that they can share something with me that I'm not necessarily then going to immediately share with their injured loved one as well. So there's a lot of thinking that will go into how do we contract this confidentiality in a way that's ethical, that's safe, follows best practice guidance, but that also both creates a situation where key family members can be included, but also where stories can be shared that might not be appropriate or helpful to be shared with the rest of the family as well. So I might say that we have this kind of in the room confidentiality, in a way that I often will work with the whole family, and I might see people individually. And again, that's different to common practice in clinical psychology a lot of the time, which is much more individually focused. And we might contract, that what you tell me when we meet, and there'll be limitations to that around safeguarding, of course, that stays in the room between us, but then also it's really important for me to be able to bring that neuropsychological understanding of the brain injury, and to be able to support family members to understand what they're seeing in the context of the brain injury. So again, then there's that confidentiality that I might have gained to be able to share information. So there's this kind of complex weaving of holding information and sharing information that I try to do in the most transparent way possible. But probably comes across, it can be complicated as well. But ultimately, I find that whilst there are resources and constraints to working in that way, I find that that's what enables me to be most helpful to the families that I work with.
And bringing the child into this, what can parents and other people do to support the well-being of a child or young person after the parent experiences encephalitis or a brain injury?
Well, that's a really important question because there are lots of things that can be done. And what I would say is that parenting and brain injury, that this is part of my professional experience. It's not part of my lived experience. So I'll have ideas and suggestions that will be born out of my knowledge and my practice. And hopefully some of those are helpful for some families some of the time, but other times they won't be helpful. So I've got ideas and thoughts, but I guess it's just sharing it with that caveat as well. So I think that what's really important is that there's a coming together of other important people and adults in that young person's life. So that aunts and uncles and grandparents and the non-injured parent, to the extent that they're in a position to be able to, and older siblings, that there is a showing up for them, that's really, really important, because those other relationships can become even more important than they were before. Getting that sense of consistency and perhaps taking up some of the role that the injured parent might not be in a position to provide at that time. So I think that that's something that's really important. I think that children and young people, they need different things at different times. So early on, often actually what's needed is information. So information that's delivered in a developmentally appropriate way that can be understood. So, having a story to hang it around what's happened, that it's possible for the young person to understand. And we live in the age of the AI revolution, and there are lots of wonderful tools that you can use to put in a 5 or 10 line story and get some of these AI tools to make a storybook for the young person. And so these stories need to have this kind of balance, don't they, between what's happened and some sense of continuity and hopefulness. So continuity is this, this sense that if we step into narrative psychology, we make sense of the world through stories. We're storytelling beings as human beings, and we have stories about ourselves and about the world and about our family members, about everything. It's kind of similar to the schema, but from a different school of psychology. And so stories that tend to support well-being will be ones where there's a sense of continuity. So I've lost my parent, they're not the same as they were. That's something that's really important to hear and to validate and acknowledge, whilst also making space for noticing what's the same and where's that continuity, and to support them to pay attention to that. Because if it's possible to have a different story that's more like, my mother, she became unwell, she sustained this encephalitis, she had a brain injury, and now these are the things that she finds difficult, and these are the things that are still the same. So if there's a sense of they're still mum or dad, then that can be very protective for children and young people. So if we're coming back to this idea of perhaps playing around with AI and get it to make a storybook, or other people might be more artistic than me, and they might just draw the pictures, and that can be just as good. Or even with the young person as well, and it might be actually just, how do we have a story that includes what was going on before, then becoming unwell, what's changed, what's the same, and then something about the future with a hopeful edge aspect to it, I think. So, we make sense of the world through stories, and stories are how we process difficult events, and it's how we have a sense of continuity. So I think it's really important to create space for children to be able to tell their stories, and for that to be heard and validated and listened to. And it might be that story needs to be told and retold again and again. And that might be in different ways, depending on the age and developmental stage of the child. And so I think supporting them by hearing that story, but perhaps also in supporting them to construct a story, which may include, a physical drawings in a physical writing book, or even acting something out with dolls. That can be something that's really helpful for supporting children and young people to process and make sense of what's happened. I think that's another thing that can help. I think communication is really important. So making sure that schools, GP, other professionals involved are aware of what's happened and what's going on at home. That can be really key. I talked about education. It can be both education about, what's happened to the parent, but also what can you expect things to be like for yourself. That's often something that's missing in services, is actually supporting family members to understand how this can affect them. Because often when family members experience this kind of trauma or this kind of ambiguous loss, the distress can remain for years or decades later. It can be a kind of frozen grief that can stay there. And if family members aren't supported to understand that, then they can have a sense that there's something wrong with them, or that they're going crazy, or they're going mad. Why do I still feel this way? They're still here, they're doing quite well, but actually that's really natural and to be expected, that there can be that kind of persistent distress. So I think helping the child or young person to understand that they might have difficult feelings, and that's to be expected, or if they're starting to show behaviors that are challenging to manage, perhaps to support that young person to understand what they're doing and what they're showing in the context of what's happened to them. Those can be things that can be really helpful and important as well. I'm just trying to have a think of perhaps a few other things might come to me.
Absolutely, yeah. There's so much to talk about. So thank you so much for that, Dr. Byrne. Just to carry on the lighter note, could you talk about examples of post-injury growth in parents, such as new perspectives, deeper empathy, or strengthened family bonds?
Yeah, absolutely. Before I answer that question, just one other thing might be actually just for the non-injured parent to try and create some one-to-one time with the young person, whether even that's like 5 minutes a day or an hour each week. Yeah, actually just that can be just one thing that can be helpful, is just having that one-to-one time with the young person. So your question was about examples of post-traumatic growth within families and parents, you say? Yeah. So so I have a family that I work with, and I'll anonymize the details, and they have given their consent for me to share their information, where the mother sustained an injury, and a significant injury impacting on levels of fatigue and her communication and executive functions. And this was something that was really, really challenging for her daughter, and came, an important developmental stage for her, as she was, approaching secondary school. And she had her sense was that family life went from being very fun and light and colorful to very quickly being very dark, being very lonely, that dad had to work, and that she had to provide a really high level of care for her mum. And unfortunately, as part of the journey through her acute hospital stays, this young person was exposed to seeing her mum in a really, really unwell state, which had a profound impact on her, and a sense that she wasn't protected by services in the way that she should have been. And so she was dealing with these the trauma. She was dealing with the loss of her mum as she perceived it, and a sense of family life really, really changing, and therefore, then not having the support that was developmentally appropriate that she needed at that time in her life, around getting dressed in the morning and eating and help with homework. So when we met, she'd been dealing with this for a few years, which was a very difficult situation, and I think it was very painful for the parents, because like any parents, they wanted to protect their daughter from some of the harsh realities of the world, and in particular for the mum, that her sense, because she'd lost this period of time to coma and this kind of post amnesia, her sense was that then she came out into a different family that was there before. So her sense then was that her daughter wasn't a little girl anymore, that she was a young woman, and that she didn't need her in quite the same way. And while she had been in hospital, the daughter had become much closer to the father, and started to take on much more of his interests. And so, for instance, they gave the example of a birthday or Christmas, and the mum being really confused about the presents that her daughter was receiving. And so, because they were things that were really different to what she would have liked before, but she seemed happy to receiving these, and so there was this real sense of isolation and confusion that occurred, which inevitably then creates a distance and a pulling away from one another. And what would happen is then, whenever mum would show symptoms of the brain injury in terms of the fatigue and the communication changes, was that they would send the daughter into this very paralyzing state, in this very distressed, traumatized state, where she didn't know how to make sense of it or what to do in that situation. And so the support that's been in place has been over a longer term period of a couple of years now. And it's been a combination of individual trauma-focused therapy for the young person. There's a multidisciplinary team in place where support's put in place for mum and dad as well. But also working within this single session family consultation framework, which is from the Bovary Centre's work in Melbourne. Got these really lovely models of working with families after brain injury. Because in the UK and in many places, what tends to happen is someone's unwell and they might get a period of rehabilitation where they're supported to regain some of the skills. And that typically happens in one burst after the illness. And then they're discharged in the community with very little support. It varies, it does, but then family are really there to take a key role, and it's then really difficult to get back into services for further rehabilitation. Whereas the Bovary Centre developed this lovely model of single session working, or they also called it long-term intermittent therapy. The families might come along just for one session, just to talk about and work on something that's really, really important. And that one session might be enough, or it might be that they come for 2 or 3 meetings and then they go away and work on things, and then they might represent a year later, even 10 years later, and they can access the service. So that was something that was really inspirational for me, and that shaped my work with this family. And so we'd have these intermittent meetings, and we might do things like what I would think of as like a sequence. So we think about an afternoon in the family that didn't go in the way that they might have wanted it to, where mum might have been fatigued and it resulted in a falling out, and there may be a sense that the daughter and the partner are very allied, and mum then feels more excluded, and then everyone ends up withdrawing into their own space and dealing with their own distress and trauma, where we might just kind of map that out, and we might just look at that and might just slow it down and just think, how are different people feeling as we went through that? What types of thoughts were we having? Did it resonate with any other traumas along the way in your journey? So just to slow down, create space, and create different opportunities for communicating and interacting in different ways. Or we might use something in family therapy is called circular questions, or interventive interviewing, another one of the fancy words that they might use for it, where we use particular questions that are designed in such a way to get people to slow down and to think about things from each other's point of view, or to think about what might be possible in different ways. And so it might be thinking about, Mum, if you were managing your fatigue in a different way, what impact might that have on your daughter? What impact might that have on your relationship with your partner? What impact might that have, in your relationship with your daughter 5 years down the line? So getting people to slow down and to think about what opportunities there might be to manage things differently. And sometimes that's about that optimization of the rehab and how people engage with it. And actually, with this family in particular, here for the mum, hearing actually how the fatigue and other symptoms were impacting on her daughter was a real key moment in shifting things, actually realizing I need to do things differently here. I need to work with my team to manage my fatigue in a different way, so that these other symptoms of the brain injury aren't presenting and then impacting on her daughter and on their relationship. So that's just a brief snippet of what some of the psychological support might look like for individuals and families after a brain injury such as that caused by encephalitis.
Amazing. Thank you, Dr. Byrne. We have come towards the end of the questions. And I was just wondering if you can tell us a little bit about the work you're doing at Living with ABI Limited.
Yeah, thank you. So that piece of work we just described is one example. So we've got a growing team of clinicians where we're systemically trained or orientated, but experienced in neuropsychology, which is the field of practice that's traditionally supporting acquired brain injury survivors. So it's this meeting of these two worlds of systemic family therapy and neuropsychology, which can be really different ways of thinking and understanding people, but each can bring wonderful resources and strengths as well. So typically we're providing these specialist psychological assessments and therapies for families living with acquired brain injury. And we develop new pathways as well. So living safely with ABI, where some people who are living with acquired brain injury might start to go on to develop risky or dangerous behaviors, either to themselves or others. And so there we deliver like unique services, including forensic psychology and providing clinical leadership to make sure that these people they're understood by statutory services like social services through this brain injury lens, and that the right support is put in place. And we try to stay research active. So we've got some book chapters coming out in the next year or so, either neuropsychologically informed ideas in systemic books, or systemically informed ideas in more traditional neuropsychology books, and some papers and grants that are hopefully going to come to fruition in the next year or so. So yeah, it's an exciting time for us as an organization, and we've got a wonderful growing team. So yeah, thank you for asking.
Brilliant. Thank you. Yeah, looking forward to all the best with the chapters as well. So we have come to the end of the podcast. I just wanted to give you a chance before closing to say anything that we haven't discussed that you'd like to mention.
Well, I think that, I'm conscious that you've got a really broad international audience for both encephalitis survivors, their families, and some professionals as well. And I think it is just, for me, it's that message to professionals to really hold the child in mind, because that can be more difficult for families after encephalitis or another brain injury, to hold the children in mind and to hold their needs in mind. And the risk is that then that gets mirrored in professional systems. And, often that there are lots of barriers to that, but there can be real quick wins as well. So if you were to stop off on your way to work at a charity shop and just buy a small box of toys and put that in your waiting room, and maybe once a week when you're having your tea or coffee in the morning, just make sure that they're all in good nick, and do any of them just need a quick wash or anything like that. It's just like one small thing that you can do that actually just shows, this, what we're thinking about children. When you walk into your workplace, just take a moment to look around and think, what might this look like through the eyes of a child? In a scary situation where a parent might be unwell, and is there anything that we can just change up to make sure actually that we're showing that we're thinking about those children? And even if it's just one or two children across the whole of your career, that have that slightly different journey, a slightly different experience as a result of it, I think that's worth it.
Lovely. Thank you so much, Dr. Byrne, for sharing your valuable expertise with us. It's been a pleasure to have you on the podcast.
Thank you, Prav.
That was Dr. Freddie Byrne, clinical psychologist and clinical director of Living with ABI Limited. And I'd like to thank you, the audience, for listening and watching. If you have been affected by any of the issues raised wherever you live in the world, please contact our support services. Encephalitis International is here to help in whatever way we can to achieve our aim of ending death and disability from encephalitis. For all our information, as well as details on how to donate, please see the podcast description or visit www.encephalitis.info/donate. Thank you again, and see you next time on the Encephalitis Podcast.